Welcome to a new episode of the EADV Podcast. Join host Professor Carle Paul in conversation with Professor Michel Gilliet, a leading expert in skin immunology and Chairman of Dermatology at the University of Lausanne. Together, they dive into the cutting-edge world of personalised medicine in dermatology, exploring how molecular pathway profiling is transforming diagnosis and treatment for immune-mediated skin diseases. Discover how this innovative approach is shaping precision medicine and redefining clinical practice. But before we get into it, did you know the EADV started in 1987 with 21 founding members and has now grown to over 11,000 passionate advocates for patient care in dermatology and venereology. We are a diverse community with members representing 125 different countries. If you would like to learn more about our membership benefits, or if you wish to join the community of like-minded professionals, go to eadv.org. A must-listen for dermatologists, researchers and clinicians eager to understand how molecular insights is revolutionizing skin immunology and patient care. Don't miss this engaging episode.
So welcome to the EADV Podcast. Today the EADV Podcast will be on immunology of the skin, and I'm very pleased to introduce Professor Michel Gilliet, who is with me. As you know, I'm Professor Carle Paul. I'm the editor-in-chief of the EADV, and I will be the interviewer of our expert on skin immunology, Professor Michel Gilliet.
So thank you very much, Carle, for inviting me. So my name is Michel Gilliet. I'm a professor and chairman of dermatology at the University of Lausanne in Switzerland. And I'm also currently the chair of the programming committee at the EADV.
Thank you, Michel. So, Michel, you've been an international, well-known researcher in the field of skin immunology. And a few years ago, you've developed the concept of personalized medicine for patients with immune-mediated skin diseases. Could you tell us in a nutshell, what do you mean by personalized medicine for these patients?
So personalized medicine is an approach that tries to improve patient care through analysis of the patient's disease. And this principally can occur through different ways. But what we did is we profiled the tumor of each patient in order to do personalized medicine. So what is personalized medicine? This is a concept that was developed in oncology for cancers. Initially, it was developing for breast cancer. I would like to give you an example. So in breast cancer, you have, for example, Herceptin, which targets HER2, which is a molecule. And what they did in oncology is that they started to profile the breast cancer tumor and look whether HER2 is expressed. So the target of the Herceptin is expressed. And by doing that in each patient, they could increase the responses to Herceptin. Now, we in dermatology, we have a lot of targeted therapies, as you know, for psoriasis, atopic dermatitis, etc., which target specific molecules. But we are lacking behind because we are not analyzing the tumor, the skin specimen. We don't know whether this pathway which we are targeting is actually active. So our approach was really to look whether this pathway, this inflammatory pathway in skin disease, in inflammatory skin disease, are active, and looking whether by identifying these pathways in the patient could help us to improve our diagnosis, first of all, of the patients, but also to improve the responses to the targeted treatment.
So if I understand you correctly, you are taking biopsies from the patients and you try to understand the cytokine pathway profile. Can you explain a little bit more about the process that made you come to this discovery?
Yeah, so you're absolutely right. So our goal was to identify the cytokine inflammatory profile in each of the skin specimens. And the way to do that was to select first of all, diseases which have a clear profile and which are targeted by our biologics. So, for example, psoriasis, we know it's a Th17-mediated disease. Atopic dermatitis is Th2-mediated disease. Lichen planus is Th1-mediated disease. So we took these diseases and we cross-compared their expression profiles. So the expression of this cytokine. And by cross-comparing, I think I intend so we measured the transcriptomics, so all the gene expression, and we cross-compared them. So we looked which genes are upregulated in one disease, but not in the other, all the other ones. And by doing that, we could come up with a list of genes which are specific to the Th17 profile, for example, of psoriasis, with a gene list which is specific for the Th2 inflammatory profile of atopic dermatitis, and a specific gene list which defines the Th1 profile in lichen planus. So this is what I mean by cross-comparison. And so basically what we did that with a lot of skin diseases. And what we ended up at the end, we found 7 core pathways. That means gene lists for these 7 core pathways. And we think that we cannot identify many more of these pathways. These are really the core pathways we have in inflammation. So what are these pathways? They are Th1 pathway, Th2, Th17. We have innate pathway linked to type 1 interference. We have the neutrophilic pathway, and we have a macrophagic pathway and an eosinophilic pathways. So we came up with signatures, so list of genes which define this pathway. And why are these pathways so important? Because what we found is that this pathway can be used to define the disease. So we can use these pathways, either single pathways or combination of them, to diagnose the disease, and also to ascertain that they will respond to the targeted therapy by identifying the dominant pathway.
That's very nice. So if I take an example, which is close to my heart, which is hand dermatitis, it's very difficult for hand dermatitis in some patients to know, is it psoriasis, is it atopic dermatitis, is it allergic contact dermatitis? With your methods, are you able to differentiate the different pathways?
That's exactly what we are doing. So we are able, when we take a specimen from hand dermatitis, to see whether it is psoriasis, whether it is atopic dermatitis, or whether it is what we call chronic hand eczema, which is not psoriasis, which is not atopic dermatitis defined by Th2, but is this pot which we define as chronic hand dermatitis, which is possibly related to allergic contact dermatitis, but often we don't find the allergen. So that's exactly what we do. So what we take the specimen, and we can what we call cluster it into a cartography which we have built. So we have multiple diseases. We have created cartography, and when we analyze our specimen from the pulmonary dermatitis, we can then cluster it within this cartography and see whether it goes towards psoriasis, whether it goes towards atopic dermatitis, or whether it is in this chronic hand eczema category.
That's good. And in terms, are there other diseases for which you are able to differentiate, and where the identification of the pathway has clinical utility in terms of the drug you will choose?
Yes, so this is exactly where we want to go. So first of all, I would like to mention that it has a big utility in diagnosis, in the diagnosis aid, because we have cases which are unclear. In our clinics, we often see, we always talk about psoriasis and atopic dermatitis, but when we go to our daily clinic, sometimes we have cases where it's difficult to differentiate. We have some eczematous psoriasis, we have some psoriasiform eczema, so it is difficult. And what we can do is, by taking our approach, first of all, we can classify them clearly either in psoriasis or atopic dermatitis or other disease. We have also a study, we have shown that erythroderma, which is often difficult to diagnose by histology because it's a very acute inflammation, we can clearly say from the start, this is a psoriasis, this is an atopic dermatitis, this is a PRP, pityriasis rubra-pilaris, or this is a drug-related adverse event. So we have this approach can help us to diagnose reliably the disease. The other point that you made is the choice of the targeted therapy. So what we did a study with 80 patients under biologics, and we shown that if we do this analysis prior to give them a biologic, we can increase our success rate because we can eliminate what we call mismatch. So if we find, for example, if you have a patient we want to put onto a dupilumab, an anti-IL-4 receptor, and we suddenly realize that actually the Th2 profile is not the dominant one, we know that it's never going to respond. So if we do this profiling prior to introducing our biologics, we have the chance to eliminate what we call the mismatch and thereby increase our chance to respond.
That's a fantastic advancement, because it's clear that in some clinical situations, like eczematous reaction in older people, we do sometimes confrontation between the clinic and the histology, and we are stuck with the histology. So how do you explain that histology is not informative and that your molecular approach is much better?
So that's of course a great question. I think, and this was what we learned from erythroderma. I think often we have a very acute inflammation that's in erythroderma, and when we biopsy, this precedes the full development of the epidermal phenotype, which is linked, of course, to the inflammation. I mean, we don't have this clear psoriasiform reaction in psoriasis or eczematous form in atopic eczema, but we are at very early stages of inflammation, where in histology you don't have the full-blown morphology developed yet, but we can see already the type of inflammation. So that's why I think the success of this approach surpasses what is the histological approach.
That's good. So in practice, you do a biopsy, you perform your transcriptomic analysis. I think after that there is some bioinformatic analysis. So how long does it take from the time to take the biopsy and the time you get the information that will be useful for the patient?
So a long story short, we have it down now, so we can do from the biopsy all the way to having the results and discussing the results with the clinicians, or it takes 2 weeks. So we have now in our clinic, we do this on a routine basis. So we have 12 samples per week. We are doing 12 patients per week. There is a cartridge of 12. That's why. So we accumulate up to 12, but we can fill up the cartridge within a week, and then we analyze it, and the whole process until we discuss the patient in a molecular board, which we have now in our clinic, and we give a report back. It will take 2 weeks.
And how do you think the future evolution of this technique, for example, the generalization and the large use, in the community, because it's very useful for many patients for whom we prescribe a drug and then we fail, and we prescribe a second drug and it costs a lot of time and a lot of money too. So how do you see this technique to be generalized in the future? What's your vision regarding the future?
Yeah, so we are absolutely excited about these developments and this technique at my clinics, and we are, as I said, we are really doing this on a routine basis. And the more we use it, the more we feel the need to use it, right? So it's becoming something very important, and we are ready, and we want to share it we started to share it, the possibility to send us samples over Switzerland, but we are trying now, and I think this will be the future, to have a network throughout Europe of centers which can do it. We are ready to share our database, so this cartography which we have built. So far, of course, the limit is we are linked to a special type of transcriptomics. We are doing it. It's a technique called nanostring. So we are looking for centers that have a nanostring and that can share these. We will share protocols, we will share bioinformatics capacities, we'll share the database with them and try to create a network of users across Europe. And our vision is that this, will be used by other centers and will move our discipline forward with this precision medicine approach.
Thank you, Michel. That's very exciting. And did you see any interest from the manufacturers of the biologicals to help you? Because it's also an advantage for them to profile their drug in the right patient, actually.
Yeah, that is a good point. We have not gone in this direction yet. We are so excited about this technique that I think my first vision is really to share it across Europe and to have other people that share this excitement and that this technique is used. And of course, there are many other possibilities. One is exactly with industry definitely will have interest also to try, even in their trials, to increase their response rate by eliminating this mismatch, which we always have in there. Another thing this approach is interesting is to repurpose certain drugs. We can clearly identify the target, so we can analyze diseases which are so far are not clear what pathways are actually activated, and that could lead to repurposing of the drugs. We could also use this approach to identify new candidates for that drug development, of course.
Good. I have two small questions. The first is, do you think it will be possible in the future to couple this analysis with histology, doing some kind of single cell analysis? Do you think it might be possible? That's my first question.
I think definitely we want to go back, once we have now these profiles, we want to go back to histology and understand what are the links. Through artificial intelligence approach, of course, we want to see whether we can, in histology, we could directly, just by an H&E staining morphology, we can define the profiles we identify molecularly. This is definitely something we want to do. Another thing we want to do on histology is that the signature, so these genes that we identify, which define one pathway, whether we could just multiplex it on histology with antibody stainings, which of course would reduce the time until we have the results. So just a simple panel of antibodies, and we will have the results the next day. So these are things we are thinking of and we are trying to develop.
Beautiful. That's beautiful. Very exciting. My last question is more questions related to one disease, pityriasis rubra pilaris. It's a very difficult disease to treat. Some people say it's Th17. Other, it's more, IL-23, part of Th17. What's your view on that now you have accumulated such large experience?
So yes, we have profiled also pityriasis rubra pilaris, and this is a work done by somebody who's a collaborator in the department, Kurdin Konrad, and you were also initially part of that, Carle. So we have very exciting results. Which we clearly see that there is a common Th17 pathway with psoriasis, but there is an additional signature which defines pityriasis rubra pilaris. And so we are very interested, and Kurdin is working at that, to know a little more what are the specificities and why we see a couple of genes which are specifically upregulated in the context of this Th17 disease.
Fantastic. So it's a message of hope for the patients who who we cannot categorize with clinical and histological means. And I think we are all very excited about this advancement in immunology of the skin. If you want to give a last message for the audience, for the dermatologist audience, what would you say to them regarding how the future looks like?
Well, the future is always bright, but I think that this approach, so this molecular profiling, is really a next step in the development of our discipline. We have had so much advances in the past 20 years with targeted therapy, so we are really a leading specialty medicine in this. I think we need also to have this molecular counterpart to identify what is actually going on in the patient, to develop this personalized medicine approach in our discipline. I think personalized medicine has been, everybody knows about personalized medicine, but nobody's really doing it. So I think now it's a time we can implement this into clinical practice with a big value that I hope I could convince you. I hope that I will be able to show this in the future even more. And I think this will complement our daily practice. I truly hope that.
Thank you, Michel.
Thank you, Carle.
We would like to give a special thank you to all our listeners. If you haven't already, make sure you subscribe on Apple Podcasts, follow us on Spotify, or otherwise find us on any major podcast provider. We appreciate you joining us and look forward to presenting more interviews, research, and other topics of merit. Until the next episode, take care of your skin.